Well, good evening, everyone. My name is Adonis. I think everyone knows me as Dr. Piloto. Today we're going to talk about diffuse glioma in adult and pediatric population. I think for young neurosurgeon is one of the most challenged um, tumor, not because of the complexity of the surgery, but because of the most of the patients that have tumors like that usually have known or poor neurological symptoms or sometimes neurological intact. And also because of the necessity to use more than one diagnosis method to to create a plan in order to operate or, or order medical management. The low-grade glioma, initially the most of the doctor thought that it originated from the glial um, cells, so a neuroepithelial tissue. At the moment, the cell of origin remain a mystery. Um, is considered the most common primary intracranial tumor seen in adults, and there are several risk factors that have been identified of a potential contribution, which include European ethnicity, increase in age, and exposure of ionizing radiation. This type of tumor is most common in population between 30 and 55 years age, and less common in patients with history of seasonal allergies. Disease prevalence worldwide may be strongly influenced by the availability of biochemical emissions. The introduction of CT scan and MRI in 1970 and 1980 led to an increase in prevalence of this type of tumor. There is a familial tumor predisposition syndrome associated with an increasing risk for diffuse glioma, include neurofibromatosis type 1 and Frommeni syndrome and Leach syndrome that was discussed in the previous conference. However, and neurofibromatosis 1 is most often associated with pilocytic astrocytoma, and Li-Fraumeni and Lynch syndrome are most often associated with glioblastoma as opposite to diffuse low-grade glioma. 4% of gliomas cases are associated with familial cluster involving first-degree relative, and large multi-institutional genetic epidemiology population study had identified numerous genomic variants associated with increased risk of development glioma. We mentioned low-grade glioma occur most commonly in younger age group between 20 and 40. The peak of incidence for oligo is 40 to 45 years, whereas for astrocytoma is 30 to 40 years. So low-grade glioma are slightly more common in male population. Some environmental risk factors have been identified as a history of exposure of ionizing radiation is associated with an increase of lifetime risk of glioma. Israeli children treated with tinea capitis with scalp radiation were found to have an increased lifetime risk for glioma with a relative risk of 2.6. Immunologic illnesses such as allergic rhinitis, asthma, eczema, and psoriasis remain protective against the risk of developing a glioma. And notably, regular cellular phone use is no longer questioned as a risk factor for developing a glioma, despite an initial report from an international agency for research of cancer classified cellular phone as a possible carcinogen. All subsequent study has failed to find an increased risk for glioma incidence. Histological feature of diffuse low-grade glioma. Diffuse low-grade glioma include diffuse astrocytoma and oligodendroglioma. Oligoastrocytoma is no longer supported based on molecular study. By definition, diffuse astrocytoma and oligo are diffusely infiltrate glioma that widely infiltrate into surround brain parenchyma. parenchyma. Establishment of an infiltrative growth pattern in the biopsy or resection specimen from a diffuse glioma is based on the presence of entrapment, normal brain element in the background. Immunohistochemical staining for neurofilament protein can be used to highlight the presence of entrap axon among the tumor cells. Um, this is a screenshot from the Greenberg in 2006. I was in the residence in that moment. That was basically the classification that was discussed already for glioma that we use, that I think most of the from my generation use as simple classification. And there is if you see here, the approximate survivor for astrocytoma for grade 1, 8 to 10 years, and for grade 2, 7 to 8 years. And the classification most likely was based on the hypercellularity, pleomorphism, vascular proliferation, and necrosis. And of course, the classification was based on grade 1 and grade 2 and grade 3 and 4, and was widely used and quite useful for surgeon. Um, Histologically, the common pattern of infiltrative growth frequency observed in diffuse glioma termed secondary structures of Shearer include perilesional satellitosis and perivascular aggregation, the second images here, and the subpial condensation seen in the third images. For diffuse astrocytoma, the histological appearance have typically an ovoid elongate nuclei with the irregular nuclei contour and condensed chromatin. The tumor cells of diffuse astrocytoma often have a little or not discernible cytoplasm, which have been termed the fibrillar variants. Less commonly have an eccentric bellies of eosinophilic cytoplasm termed hemistocystic. Oligodendroglioma typically have an monomorphic round nuclei with delicate chromatin, small pinpoint nucleoli, crisp nuclei membrane, and clear perinuclear halos, impairing and fry eggs appearance seen in that images here, and with hematoxylin um, and eosin. This is the fluorogram in order to diagnose the low and grade glioma. For low-grade glioma, we consider, of course, the IDH1 and 2 mutation, the TP53 mutation, and ATRX inactivation. For grade 2 glioma and for oligo, the chromosomes 1p19q codylation, TERT promoter CIC, and FUBP1 mutation. Usually that classification for in order to be on the standard is very unpractical for surgeon. It's more it was useful for oncology doctors. So it's just a brief explanation what IDH does mean for those who like biochemistry. IDH is isocitrate dehydrogenase is an enzyme that converts in the Krebs cycle isocitrate to alpha ketoglutamate. When there is a mutation in the IDH, this mutation will convert alpha ketoglutamate to um, to to hydroxyglutamate. This is this onco oncometabolites is the main reason because of the tumor, because of increased the risk of tumor. This also IDH1 and 2 is not only an enzyme that is increased or is present in tumor, in glioma tumor, is also seen in another kind of tumor like sinus nasal undifferentiated carcinoma, in glioma, as we mentioned, papillary thyroid carcinoma, cholangiocarcinoma, solid papillary carcinoma with reverse polarity, and colorectal cancer, chondrosarcoma, acute myeloid leukemia, myeloproliferative neoplasm, myelodysplastic syndrome, and autoimmunoblastic T-cell lymphomas. Okay, so how we explain here the conversion with the isocitrate to glutamate that require from IDH. When it's a mutation of IDH, there's an increase of the two HG that block most of the mechanism that protect the body from the oncoproliferation. In terms of emissions, MRI remain as a gold standard of the diagnosis of that type of tumor, usually with gadolinium. On emissions, these tumors classically appear homogeneous in all modalities. They can in fact be difficult to detect by CT scan, as they tend to be close in density to the background brain and usually not do not enhance or make the diagnosis difficult. MRI, therefore, is more sensible that CT scanning detected these tumors. It has been well documented that neoplastic cells can potentially extend far beyond the MHS margin of the tumor as delineated by contrast enhancements on or flare hyperintensity. They display low signal in T1 images, higher signal on T2 with little or not enhancements in following gadolinium administration. As we see here, so we have an T2 image here with hypointensity images and um, T2 here with hyperintensity images here of low-grade glioma, T1 that show on a hypointensity emission, and flare that have on a hyperintensity for the enhancement for that type of tumor is very useful in terms of surgical resection. Also, that are tumor that have a poor blood supply. So usually in the relative blood, cerebral blood volume emissions, I show the tumor have to possess a relative lower vascularity. So also in the MRI spectroscopy, there is an increase of the choline respect of the N-acetyl aspartate. Remind that there is one of the main difference between high and low grade glioma, is that there is an increase in N-acetyl aspartate in high grade glioma in comparison with the collide index. There are some characteristics of routine images that may favor oligo over astrocytoma, and that include a cortical involvement, presence of calcification on CT, heterogeneous attenuation signal, including in some cases presence of intratumoral cyst. On CT, low-grade oligo dendroglioma typically appear as a non-enhancing low-density masses. Calcification is found microscopically in 90% of the oligo, and calcification may also seen on CT. Calcification is not specific to oligo, but is quite common. MRI is superior to CT scan delineating this tumor, which appear as a regional area of increased signal on T2 and flare images. They frequently involve the cortex, which likely explain the high incidence of seizures in these patients. They might be large at the time of presentation. Oligo are frequently heterogeneous in T1 images, and cyst, an area of hemorrhage, might be present too. This is an example of oligodendroglioma. So we see an CT scan here that show mainly calcifications. As low-grade glioma in general also have T1 hypointensity appearance and hyperintensity T2. Um, Management and survival. The period overall survival is the 9 to 10 years for IDH mutant diffuse astrocytoma and more than 40 years in IDH mutant and 1p 19q coagulated oligodendroglioma. Well-established clinical factor that affect outcome include patient age, diagnosis, extent of the tumor resection, and performance status. Some reports suggest that greater extent of tumor resection may have a greater impact of overall survival for patients with IDH mutant astrocytoma compared with oligodendroglioma. Options of treatment. Um, if for that patient, the surgery is not an option, so you're just consider biopsy as essential to confirm a diagnosis because 43% of the tumor that were thought that was a diffuse low-grade glioma on images turned out to have a high-grade glioma. Watching or waiting is one of the options, and treat include the patient surgically, symptomatically, sorry, with serial neurological exam, MHS study, interventions, prevent for progression of this tumor or radiological. Radiation therapy is another option, but is of insufficient as a monotherapy. Of course, the combination with surgery is much more effective. Chemotherapy, the optimal agents and timing of chemotherapy is not well defined. Temozolomide or PCV improve the progression-free survival and overall survival when add the radiotherapy. Temozolomide is less toxic than PCV, but is inadequate as a monotherapy and may induce hyper mutation resistant tumor cells. The surgery that is the gold standard for that, or is the best option for patient with that type of tumor, and combination with chemotherapy, radiotherapy, plus surgery, that is definitely much more effective. In the surgical management, the first step of management of the patient with suspected low-grade glioma involves surgery that provides a specimen for tissue diagnosis and, if it's possible, cyto reduction. All right, that is not the same that gross total resection. Surgical goal varying depend of the size, location, and tumor, and location of the tumor. For the patient age, functional status is another factor that need to be considered. The greater extent of the resection influence the natural history of disease by lengthening time of the malignant transformation range from 4 to 29 months. A growing body of evidence suggests that gross total resection on FLAIR tissue on MRI is associated with longer survival and longer period of seizure control. In the era of molecular diagnosis, there is a renewed focus on determining the impact of extent of tumor resection across molecular subtype. IDH mutant with 1p19q co-deletion, IDH mutant with intact chromosome, 1p19q. Gross total resection result in longer median overall survival and progression-free survival than not gross total resection. Surgical evaluation begin with the detailed history, symptom inventory, and physical examination. Seizures and symptoms related with perolational vasogenic edema are managed with dexamethasone doses ranges between 2 to 24 milligrams daily. Direct cortical stimulation brain mapping can be used for preservation of cortical and subcortical region of functional significant during surgical resection. The goal of the surgery um, include to obtain adequate tissue for histological and molecular study, can be accomplished with biopsy, open or needle or cytoreduction surgery. Cytoreduction, maximum safe resection with a goal of gross total resection when feasible to reduce tumor burden, which facilitate adjuvant therapy, oncology goal, to reduce mass effect, which when severe can threaten a nation and can compress and inhibit adjacent brain tissue that is still capable of functioning, to reduce intracranial pressure with large lesion, may reduce peritumoral edema, may reduce seizures frequency, and for low-grade glioma to preserve or delay the malignant transformation to 3 or 4 high-grade glioma. Resection, definition and goals. Extent of resection is reported as the percentage of original tumor volume that was removed and should be measured on emission studies since the estimate made by surgeon based on intraoperative finding are grossly inaccurate. As a metric, extent of resection failed to communicate the residual tumor burden that require monitoring and treatment, as a credible case has been made that residual tumor volume may be a more critical parameter to measure. Technical enhancement at surgery. The extent of resection is limited by infiltrate nature of diffuse glioma and their frequency location at or near a eloquent area. MHS guidance, sometimes called stereotaxis surgery, extremely useful, especially for deep tumor or in area bordering on eloquent brain. Intraoperative MRI, intraoperative diagnosis ultrasound, preoperative mapping functional MRI, can localize sensitive area of the brain. Diffusion tensor images can help localize critical fiber tracts and intraoperative mapping. Adjuvant therapies for grade 2 diffuse glioma, of course, include the radiation therapy. Early postoperative radiotherapy have been debated as an adjunct. It have been shown to prolong a median progression-free survival from 3.4 to 5.3 years, but does not affect overall survival, typically given as 54 grade in fraction of 1.8 to 8 grade over 5 to 6 weeks. Following incomplete resection, early radiation therapy significantly prolong the progression-free survival and disease-specific survival. Two prospective trials found no difference in overall survival or progression-free survival between different radiotherapy doses. The trial included 45 grade in 5 weeks versus 59.4 grade in 6.6 weeks. Side effects from whole brain radiotherapy include leukoencephalopathy and cognitive impairment. The same trial identified 5 risk factors for survival. So including the age older than 40 years old, astrocytoma histology, tumor maximum diameter more than or equal to 6 centimeter, tumor crossing the midline, that it do not apply for that tumor, and presence of neurologic impairment as time of diagnosis. Mutation in either IDH1 or IDH2 are associated with longer overall survival. Chemotherapy, the standard chemotherapy offer for patients with diffuse low-grade glioma include alkylant chemotherapeutics such as temozolomide and PCV, procarbazine, CCNU, or lomustine, and vincristine. The use of chemotherapy along with radiotherapy requires special consideration as two clinical trials focus on either PCV or temozolomide. Both studies failed to show improved survival in patients with chemotherapy alone. Temozolomide given alone for patients with IDH mutant astrocytoma is associated with progression-free survival of 2.5 to 3.5 years. PCV given alone for patients with oligodendroglioma results in a progression-free survival of 5.5 to 8 years. Molecular target chemotherapy remain an important consideration for patients with recurrent low-grade glioma, usually reserved for high-risk patients or low-risk patients with tumor progression. The VEG factor, the inhibitor bevacizumab have been studied in patients with recurrent WHO grade 2 and 3 gliomas. Immunotherapy have proven to be one of the most promising area of investigation in neuro-oncology. Several single-center and multi-center clinical studies have currently focused in promoting an immune response against IDH mutant protein. In pediatric diffuse low-grade glioma, there are several types, including the diffuse astrocytoma, MYB or MYBL1, altered CNS grade 1. This tumor is a diffuse infiltrated astroglial tumor with MYB or MYBL1 gene alteration comprise or monomorphic cells with bland round ovoid or spindle nuclei, typically present with seizures that are refractory to medications. There are two main subtypes, diffuse astrocytoma MYB altered and diffuse astrocytoma MYBL1 altered. In general, as a low-grade glioma, I have the MYBL family subtype, but there is in T2 and FLAIR, there are hyperintensity appearance in the right in that case in the right temporal occipital periventricular white matter, and there was not enhancement in T1 post contrast, and of course there is a poor perfusion as a characteristic of low-grade glioma seen in the RCBV map. The criteria to diagnose that type of patient need to be essential. There is this diffuse astrocytoma without histological feature of anaplasia, and no mutation in IDH or H3 genes, and or a structural variant of MYB or MYBL1, or DNA methylation profile aligned with diffuse astrocytoma, MYB or MYBL1 altered. Angiocentric glioma, WHO grade 1, a static or slow-growing grade 1 tumor, primarily of children and young adults, characterized by angiocentric pattern of growth, monomorphous bipolar cell, and feature of ependymal differentiation. Nearly all have MYB, QK1 gene fusion, and the rest usually have another MYB alteration. Behavior is usually indolent with little change radiographically. This is one of the example. Again, the very cortical tumor and the same pattern of low-grade glioma. Criteria include it's essential for the diagnosis, the glioma with diffuse growth architecture and a focal angiocentric pattern and monomorphic spindle cells with immunophenotypic and ultrastructural evidence of astrocytic and ependymal differentiation. Desirable lack of anaplastic fixture, alteration of MYB, and DNA methylation profile aligned with diffuse glioma. MYB or MYBL1 altered. Typically present with intractable partial epilepsy and MHS well circumscribed non-enhancing superficial or cortical base lesion, typically in the temporal or frontal lobe, occasionally in the brain stem. As a treatment, gross total resection can be achieved in most of the cases and is usually curative. Polymorphous low-grade neuroepithelial tumors of the young. Is an indolent tumor strongly with diffuse growth pattern, commonly with components resembling oligodendroglioma calcification, CD34 and hyperactivity, and a MAPK pathway activated gene abnormality. Behavior appear to be consistent with the WHO grade 1. As we mentioned before, this is a tumor that have patterns similar to oligodendroglioma, including calcification, and also there is an focal enhancement at flare and T1 post contrast, as seen in that image here. As a criteria of diagnosis, is essential diffuse growth pattern, at least regionally, and oligodendroglioma-like component, although this may be minor, and few, if any, mitotic figure. Original CD34 expression by tumor cells and by ramified neural cells in associated cerebral cortex, and IDH wild type status, and or unequivocal expression of BRAF, PV600E, or immunohistochemical assessment, or molecular diagnosis evidence of BRAF, PV600E mutation, FGFR2 or FGFR3 fusion, or potentially other MAPK pathway-driven genetic abnormality. Desirable, copious calcification characteristic or other non-constant, absence of 1P 19Q correlation. Typically present with seizures in young patients, and emissions cortical and subcortical components are typical. 80% involve the temporal lobe and usually on the right side. Tumor excision appear to be effective and improve seizures in most of the cases. Diffuse low-grade glioma, a MAPK, that is the mitogen activate protein kinase, pathway altered WHO grade 1. It's a low-grade glioma possessing astrocytic and oligodendroglial morphology and an anomaly in a gene coding for a MAPK pathway protein. This tumor is characterized by the hypointense in T1 and hyperintense is T2 in T2 as most of the low-grade glioma, and diffuse is not restrict, no enhancement is observed. Um, as a diagnosis criteria is essential diffuse glioma with absent or minimal mitotic activity and neither microvascular proliferation nor necrosis, and genetic alteration of the MAPK pathway, and IDH wild type, and H3 wild type, and absent of homozygous deletion of CDKN2A. Desirable onset in childhood, adolescence, or nearly adulthood. Absent of morphological feature of DNA methylation profile suggesting of an alternative tumor type in which FGFR or BRAF abnormality occur. Subtype include diffuse low-grade glioma, FGFR1, tyrosine kinase domain duplicate, diffuse low-grade glioma, FGFR1 mutant, diffuse low-grade glioma, BRAF and PV600E mutant, seizures of symptom related to mass effect, sometime with increase of intracranial pressure should be present in patient with that type of tumor, and in images can see appearance might be resembled that pilocytic astrocytoma complete with kystic element, with this tumor tend to be more extensive on T2 FLAIR imaging. Treatment on resolved issues related to the behavior of this group and possible subgroups. In conclusion, the patient with the WHO grade 2 oligodendroglioma and diffuse astrocytoma often present with seizures. However, symptoms vary based on tumor location and infiltration pattern. Overall survival and progression-free survival are influenced by maximal extent of resection and the use of alkylant chemotherapy such as temozolomide are given in combination with brain irritation. It remains unknown whether emergency treatment strategies such as immunotherapy or small molecular inhibition of mutant IDH protein offer a survival benefit for either newly diagnosed or recurrent diffuse low-grade glioma. Thank you.